extend a very warm welcome to all of you who have joined today in today's webinar when we are going to discuss on GI complications and liver disorders in pregnancy. Next slide, please. I would like to welcome our moderators for today's session. Our first moderator will be Dr. Srivastava. She is a past president of AOGD from the year 2020 to 2021. ICOG Governing Council member for the year 2020, fellow of minimal access surgery, and she has been trained in robotic surgery from France and also received award of APJ Abdul Kalam Excellence Awards of the Delhi Gynecological Forum. Next slide, please. Our next moderator will be Dr. Meenakshi Ahuja. She is the president of Indian Menopause Society, Delhi, member of Executive Committee, AOGAD, and also the academic secretary of Delhi Gynae Forum, member of the reproductive endocrinology of FOXI, and also past president of the DGFS. So I would like to welcome both the moderators and would request Dr. Mala to please come and take over the session. So a very warm welcome to all of you. Yeah.
Thanks, Dr. Vaishali. Good afternoon, everyone. I have the proud privilege to introduce the first star speaker of this afternoon, Dr. Sharda Jain. Madam is teacher of teachers. She is the teacher par excellence and she is a source of inspiration to all of us. Madam has been faculty for 2 decades at PGI, Chandigarh, as well as Lady Hardinge Medical College. She is the founder and Secretary General of Delhi Gynecological Forum, member and expert OB-GYN in Ethical Committee of MCI and National Medical Council. She was decorated by Lifetime Achievement Awards and Living Legend Award by many prestigious bodies. Madam has special interest in creating medical legal awareness, safety of doctors, and teaching. Madam's passion is teaching and only teaching. Today afternoon, we are going to hear from her gastrointestinal complications in pregnancy. Over to you, Madam, for your scientific deliberation.
Thank you so much for very kind words. I will just take 1 minute to get my slides on. Good afternoon, everybody, and my sincere thanks that on the Sunday afternoon, and that also when the weather is so much good outside, you have joined us to listen. The main speaker of the day is the one, Dr. Ajay Kumar, who follows me. I'm going to talk on a very simple topic, uncomplicated topic, and I have something new to add on. Is that, will be surprise to you in the end of it. And just to revise the constipation in pregnancy, which definitely affects the quality of life. Constipation as such, whether pregnancy or no pregnancy, negatively impacts the quality of life. You don't feel all right. Whether it occurs during pregnancy, during the lactation, or in a post-operative period. Now, as far as the constipation is concerned, is one of the very common problems, affecting about half of the women at some point during pregnancy and is associated with straining, hard stools, incomplete evacuation. Constipation can lead to impaired quality of life, it can lead to piles, and it definitely gives somehow a GI distress to a pregnant woman. And there are a couple of women who have history of constipation prior to conception, but this symptoms definitely gets worsened during pregnancy. There is a Rome criteria, and I think this probably will be a little new to you. At least there are 6 criteria. If 2 or more are present, then we say there is a functional constipation during pregnancy. And these are straining during at least 25% of defecation, lumpy or hard stool in at least 25% of defecation, sensation of incomplete evacuation at least 25% times of defecation. There's a sensation of anorectal obstruction or a blockage for at least 25% of defecations, and then a manual maneuver to facilitate defecation, again, at least in 25% of defecation, and fewer than 3 defecations per week. Anything more than 2 will make a candidate for functional constipation. Now, this is not our data, but this is a Cochrane review, which shows that in the first trimester, in the third trimester, in the postpartum period, nearly 1 in 4 will definitely have the problem of constipation. Now, what are the causes? Till now, we have never bothered, what can be the causes, but we all know it is because of the decreased activity of a pregnant woman as such. High level of progesterone slows down the automatic waves, which propels the food from one part to the distal part of the GI tract. Increased supplementation like vitamins, iron, calcium, again, gives rise to this particular problem of constipation. And later in pregnancy, theoretically enlarging uterus might slow onward movement of the feces. This slide beautifully sums up, all possible complications, causes which are listed in the literature are, firstly is the hormones. Progesterone induced decreased level of botulin, which stimulates the gastric activity, decreased level of relaxin, which normally inhibits GI tract smooth muscles. There can be decrease in physical activity, dietary factors like decrease in water intake, lack of fiber taking, iron supplementation, and vomiting again causes lack of water in the body. Metabolic symptoms like hypothyroidism are blamed. Iron salts are blamed. Mechanical factor I just now pointed out to you, and they can be increased colonic water absorption. Progesterone induced it is, and there can be a prolonged colonic transit time. And effect of this is that there's inhibition of gastric smooth muscle, which decreases colonic smooth muscle contractility and delays colonic transit. The result is, because of this, GI function may be disrupted for a longer time. It definitely leaves a woman with some kind of a distress. Straining during defecation may damage the pudendal nerve and impair the supportive function of the pelvic floor muscles. Disturbed defecation can result in development of a uterovaginal prolapse if she repeatedly strains. And this was news to me that constipation can lead to cesarean section rate can be increased in comparison to the people who have not had constipation. This is a literature, and I have my comments are my reserved as far as this particular comment is concerned. Now, as for the diagnosis is concerned, an extensive evaluation is usually not needed for women who present with constipation for the first time during pregnancy. So what we need to give, the non-pharmacological approach is elders say in the house, all gynecologists speak the same languages, increase your dietary fiber intake. More fruits, more salad, increase your fluid intake, and you must do some exercises. That's needed. So you find in 50% of cases, there is a relief of constipation when she increases the dietary fiber intake, fluid, as well as daily exercise. Recently, people have added probiotics that can alter the colonic flora, and this might improve the bowel functions, and there are a couple of preparations available in the market, whether they really help or not. But I know about the Japanese drink, Yakult, which my patients only tell me that they have been taking it because the elders advise them to do the same. We also know that, when you take a Isabgol or when you take a bran, especially bran, incidentally, it contains a lot of iron, and it increases the bulk of the feces and relieves the constipation quite effectively. the patient may be told that the risk of overpurgation are far greater, it does more harm than the risk of constipation. And when lifestyle and dietary modifications are not enough, you have to take laxative therapy. So just now I mentioned to you about the Subgul and the brand, which normally elders also advise at home, and we gynecologists also advise. When it is not effective, then we suggest them osmotic laxatives. And lactulose, all of you have been using for a very long time, and this is one which is prescribed. As far as the glycerin suppositories are concerned, they have been there for many, many decades, and they are supposed to be effective in mild cases. Stimulant laxatives, I have definitely have reservations. So I will definitely say that the safe ones during pregnancy are lactulose, macrogol, then glycerin suppositories and bulking agents, which just now I told brand and Isabgol. As far as to be used with cautions, I will definitely say castor oil has been used for almost 5 decades. Just before a labor, when patient passes her expected date of delivery, and elders at home only advise that you take a castor oil. And this is what I feel elder gynecologists also sometimes advise, because it can lead to it can control labor pains. And that's why during pregnancy it should not be taken, because it can definitely stimulate premature labor pains. As far as the Visacodil is concerned, to be used again with caution in pregnancy and breastfeeding mothers. So this slide finally summarizes what is the tolerability and a probiotic effect. And you can see out of all the laxatives which are given, I will say the lactulose is supposed to be better tolerated, and during pregnancy as well in lactation time, and it definitely has some prebiotic effect. Now, I will just take a case. A lady who is 35 years old lady. She's a working woman. She has a BMI of 25, weighs 65 kg. She presented with constipation during pregnancy. These are episodic constipation during the first trimester. She was recommended to increase the fiber, the water intake, and exercise. And then she found there was no relief, and there was increased intensity in second trimester, which definitely impacted her quality of life. Now, what should be done now? She's troubled. She's advised to continue all this non-pharmacological approach, like change in lifestyle and a diet modification, and the management with safer alternatives like lactulose, and the caution regarding the Visacodil. Now, why lactulose? It is an osmotic laxative. Lactulose is poorly absorbed systematically, and their use has not been associated with any adverse effects. Now, newer chewable lactulose gummies can also be given during early pregnancy, and I have had a privilege of using these particular gummies during early pregnancy, and I found they were very effective, except the cost part of it. Stimulant laxatives are approved only for a very short use, and the woman might experience unpleasant side effects, such as abdominal cramps with the use of stimulant laxatives, so they should not be used. So what should be our management approach? Continue with the non-pharmacological approaches like changes in lifestyle, some exercise, diet, and increase the fiber content of your diet. Management with the safer alternatives like lactulose. Episodic managements with stimulant laxatives like Visacodil can be done. Lactulose is not absorbed in the small intestine, and this is of great significance when treating constipation during pregnancy, as it presents no threat to the fetus in terms of premature labor. Lactulose also does not appear in the breast milk, so this particular treatment is supposed to be safe during nursing time. Laxative with prebiotic effect, suitable for diabetes as it is not absorbed in the blood. So it is recommended by FOXI, recommends it, lactulose in the management of constipation in pregnancy. The Royal College of Obstetricians and Gynecologists recommends lactulose in a post-operative management of perineal tears to facilitate passage of soft stools. In obstetric anal sphincter injury, immediate use in a postpartum phase, and in a grade 3 and 4 perineal tears when they are stitched postoperatively for 7 to 10 days to maintain soft stools, it is necessary. What about the dosage? The dosage is the starting dose is supposed to be between 15 to 45 depending upon what's your weight. Roughly it is 30 ml is normally used, and the maintenance dose a person can decide herself whether she wants to continue with 30 ml or she wants to decrease it to half. And the baby's dose are also given in children dose. This shows that they are safe for the use for younger people also. Now this is the chewable gummies. They are pretty effective. The dose is 2 gummies a day, and you find they are really useful during early pregnancy, and this is what my experience has been. It definitely has a probiotic effect. Same. So the take-home message are that constipation is the most common complaint in pregnancy. The main treatment involves increased intake of water, fiber. The routine use of laxatives should be discouraged, as having a bowel movements may come to be dependent upon their use. Enemas are generally used only for impacted stool in the rectum and not in the intestinal tract. Lactulose gummies to be tried in pregnancy by gynecologists, as far as my experience is concerned. A word about gastroesophageal reflux disease. All of us know about it, that heartburn and belching are common, possibly because the food remains in the stomach for a longer time, because the ring-like muscle, the sphincter, which is there in the lower part of the esophagus, tends to relax, allowing the stomach contents to flow backward into the esophagus, and this is what the problem is. It is reported in nearly 40 to 85% of pregnant women, usually beginning at the end of the first trimester, and can be profoundly impair the quality of life. When present, GERD persists during the entire pregnancy and usually resolves after delivery. The complications such as erosive esophagitis, bleeding, and structures are very, very rarely seen during pregnancy. The management is that you find that this is one particular problem, that at odd times patient ring you up for medication and what you need to advise. You need conservative measurements include avoiding eating late at night, elevating the head of the bed by almost 6 inches, and lying on the left side. If symptoms persist, medication may be necessary. First line of treatments are antacids. The antacids containing calcium and magnesium are considered safe in pregnancy. The patients prefer to use this medication because it relieves the symptoms promptly and can be taken on demand. No teratogenic effect of these drugs have been observed in animal studies. Bicarbonate containing agents such as sodium bicarbonate should be avoided, as they precipitate metabolic alkalosis and the fluid overload in mothers and fetus. A further concern with aluminum antacids is potential development retardation described when woman takes high doses of this particular medication. As far as H2 blocker and PPI are concerned, the histamine type 2 antagonists are often the next line of therapy. Both cimetidine and ranitidine have been used with excellent safety profiles. Although there is a safety concern with proton pump inhibitors, in recent meta-analysis, it did not find an increased risk of major congenital malformations with PPI use during pregnancy, but somehow the gynecologists are reserved as far as using these drugs during pregnancies are concerned. However, some studies in the past reported dose-related embryonic and fetal mortality in animal studies with omeprazole. PPI are nowadays considered to be safe in pregnant women and are usually reserved for GERD complications or for a woman who did not respond to previous treatments. All agents that decrease gastric acidity should be used with caution, as they can lower iron absorption, which we all gynecologists remember it. And somehow we would like Dr. Ajay to make a comment on this, but this is what it is, that as far as PPIs are concerned, they are supposed to be safe now to be used for use in pregnancy. So with these words, I think I end my talk, and we will reserve few answers when you ask me in the end.
Thanks, madam. You have rightly said that constipation and gastroesophageal reflux disease can affect the quality of life of pregnant women. But definitely lifestyle modification, diet modification, and exercise can help. Sometimes we have to resort to the medical management whenever necessary. Over to you, Dr. Meenakshi, for the next scientific deliberation of the afternoon.
Thank you so much, Dr. Mala.